morning, good afternoon, and good evening. Welcome all of you to the 85th live program on orthopedic principles. This time, our guest faculty is Professor Jehangir John Asghar from the United States. Dr. Asghar is a spine surgeon bringing over 18 years of quality care and experience to the Cantor Spine Center at the Paley Orthopedic Institute in Florida. At the center, Dr. Asghar oversees clinical research, ultrasonic and robotic technologies for adult and pediatric scoliosis. His particular concentration lies in the treatment of patients of all ages with scoliosis and complex deformities of the spine. Dr. Asghar utilizes cutting-edge technology and a holistic approach when treating patients. Dr. Asghar attended St. George University School of Medicine in West Indies, Grenada, and completed his residency in orthopedic surgery at the University of Medicine and Dentistry of New Jersey in Newark. He finished a fellowship in complex spine and spine deformity at the Shirley's Hospital for Children in Philadelphia, Pennsylvania. Before his time at Cantor Spine Center, Paley, Dr. Asghar was part of the team at Nicklaus Children's Hospital in Miami, Florida. He is board eligible with American Board of Orthopedic Surgery. Dr. Asghar has published over 40 times, and his charitable work in pediatric spinal deformities and scoliosis has taken him to service trips across the world. He has performed surgeries and aided communities in Asia, South America, and the Middle East. He's a founding member of the Society for Minimally Invasive Spine Surgery and a member of the Scoliosis Research Society, the North American Spine Society, Florida Orthopedic Society, and the International Society of Advancement of Spine Surgery. So today, it's my great honor to introduce you to Professor John Asghar for this lecture on neuromuscular scoliosis. Over to you, Prof.
Hey, how are you? Thank you again, Hitesh. So I'll be speaking specifically to the pediatric deformity and neuromuscular scoliosis. That was the talk that I was charged with. Kind of my practice right now is primarily it's 50-50 pediatric and 50-50 adult. Most of my practice is deformity or revision surgery, so people who've had previous surgery before. Here are my disclosures. I've got a number, and one of the long-standing sayings that I've learned and I've kind of taken with me from my senior partner and mentor is repetition is the hallmark of adult education. I think that's a combination of useful information and a backhanded insult, but it works out really well in explaining how, as spine surgeons and specifically scoliosis surgeons, practice and time makes you better, right? My practice volume for scoliosis from the pediatric side is about 120 cases per year, with a majority of them being AIS, neuromuscular, congenital, and other revisions as well. So what is neuromuscular scoliosis? Neuromuscular scoliosis are curves without congenital or structural anomalies with an underlying disorder of the brain, spinal cord, or muscular system. You can break it down into kind of a neuropathic cause or a myopathic cause, so the origin being at the nerves or origin being at the level of the muscles. Furthermore, you can kind of break it down as upper motor neurons, more of the spastic type, and lower motor neurons, things like that are more analogous to spinal cord injuries. Lower motor neuron conditions. You can have spastic or flaccid or hypotonic as well. From that, we can kind of predict progression, specifically with things like ambulatory status, the genotype, the genetics of the curve, the phenotype, and other medical conditions. Lower motor neuron versions of scoliosis are poliomyelitis, trauma, spinal muscular atrophy. Upper motor neurons, you have, again, most commonly is cerebral palsy, syringomyelia, Friedreich's ataxia, Charcot-Marie tooth. And on the neuromuscular side, you have Duchenne's, Becker's muscular dystrophy, and other neuromuscular or muscular-based genetic conditions. Typically for mild Scoliosis, the primary treatment of option of treatment is observation. So mild curves, it's perfectly okay to observe. Um, when the curve starts to show evidence of progression, especially in patients that are primary sitters, that's where you start to bring in seating modifications. And then we can also discuss the role of TLSOs or bracing in scoliosis with neuromuscular origins, which is probably a little more controversial. So conservative management really focuses on bracing, and that results on that are kind of variable. Some advocate for it, some don't. Things you have to kind of note with patients with who are braced for scoliosis is oftentimes if they're insensate or unable to communicate, that they may have skin or other issues that arise from not from the brace that they're not able to convey. The higher the tone, the more stiff the curve, the poorer the results tend to be with it. Go ahead. Seating modifications don't effectively treat the scoliosis, but they treat the symptomatic issues related to scoliosis, specifically with sitting balance. So a lot of times as the pelvic obliquity associated with neuromuscular scoliosis develops, you have to modify the wheelchair to be able to accommodate for that, so the patient or the child is be able to maintain an upright posture. This is also good because it allows for improved sitting tolerance, interaction with the world, and social interactions as well. Okay. And then simple observation is appropriate in many of these mild curves that are not progressive. It is important to try to maintain ambulation when we can, because we do know that the ambulatory type of patients who are able to ambulate are less likely to progress. So it's important to keep the kids walking. So, however, you do have to follow these curves closely, because you can have a mild or moderate curve, which is static, but it can progress in the size of the curves, in the likelihood of progression is different from AIS. So I oftentimes will watch these kids a little closer than I may do a static AIS curve of a similar size in a scoliotically mature patient. So when we speak to surgery, who benefits from it, right? It is curves that are larger than 60 degrees that are relatively stiff. Sagittal deformity, this is a little bit debatable, but 70 degrees that are relatively stiff and progressive. Patients with pain or intolerance or sitting imbalance issues. So they have trouble sitting in the wheelchair. You can't modify the wheelchair well enough. Personally, I divide these patients into three types when I'm deciding for surgery. And basically, you can do that with the families. So there's the early intervention type, the middle intervention type, and the late intervention types. And families kind of fall into one of those three categories. So families, as soon as they see the scoliosis, as soon as we know it's going to be progressive, as soon as we know it's going to change, there's a group of patients, families who want the curve intervened on at 50 degrees, which is appropriate. And we have some data that the outcomes in the complications in those through the harm study group may be lower. Then we have the patients that are later interveners, where they don't want anything done until the patient is, they don't want anything done, or if when it's done, it's only when the patients are symptomatic, meaning progressive sitting intolerance and issues like that. And then there's the non-interveners, the people who don't want anything done at all. What I find is most people fall into that symptomatic group. So a lot of times the curve magnitude matters less in those families. It's more often when they start to show symptoms from it. And I counsel the patients in all three. The non-operative group, what I often find is they're non-operative until they're not. And then you end up having very complex and large curves that you have to end up treating where the risk goes up to the family. And so when I speak to my families, I always divide it into the three early interveners, symptomatic, and late or non-intervention groups. And it kind of gives patients, families a sense of where they are and how we're going to follow them and counsel them in terms of treatment. So in the neuromuscular groups, 25 cerebral palsy, scoliosis occurs in about half of those patients. There's a really high risk of continued progression after about 40 degrees. The scoliosis itself is associated with muscular imbalance, right? There's an increased risk of scoliosis in patients that are spastic, right? And they tend to develop it a little bit earlier. Increased risk of scoliosis and progressive scoliosis in patients that are not ambulatory. That's why in a lot of the conditions, the neuromuscular conditions, when we can maintain ambulation, that becomes very important. It's also important for us to recognize the types of cerebral palsy and the impact that has on their scoliosis and how we manage them. So patients with monoplegia, so one limb usually affected, let's say it's the right upper extremity, oftentimes will have a very mild scoliosis that is associated with the postural scoliosis with it's associated with it's beneficial for the function. The same happens in patients with brachial plexus injuries. They often develop this upper thoracic mild scoliosis that's not progressive in nature. Personally, I think it may have something to do with differential pull in terms of the way the muscles sit on the periscapular muscles attached to the spine, but you'll often see them have a relatively mild scoliosis, and that tends to be non-progressive, and you can watch that pretty conservatively. You have patients with hemiplegia, which is it affects one side of the body, the right or the left. Diplegia, where it's symmetrical with the arms and the legs, or you can have quadriplegia, where all four are affected. Again, for bracing for cerebral palsy, it's important to brace for flexible curves. For patients that really aren't candidates for surgery, this is controversial. Most people aren't big fans of this. I still see, especially in flexible curves, I still see some value in it. The other part I do like it for is, again, the ability for my patients to go through OT and PT a little bit better. And that's always important. The type of brace you use is one of those things. I tend to use a hard shell TLSO, especially the flexible curves. I don't think the data for a soft TLSO, and in my hands, my anecdotal experience with it has been less than ideal. So I'm not a big fan of the soft TLSO for these. Here we have a patient who presented with hypotonic scoliosis. Again, we started seeing the patient at the age of 2, treated with wheelchair modifications and a soft TLSO. And over time, it has continued to progress. And then at 7 years, here are the curve magnitudes, and you see that it's about 78 degrees or on the bends. Okay, so for this particular patient, what we did was we were able to maintain the patient in a course of traction and utilize a magnetic rod to control the curve. The other issue with patients with hypotonic cerebral palsy is head and neck control. I personally suspect that that may have a correlation with issues around PJK and drop head phenomenon that may sometimes happen post cerebral palsy surgery. So it is always something that's important to care for and keep an eye on out for. And it can be a pretty difficult problem once they develop dropped head, because a drop head deformity, because oftentimes that'll affect the swallowing and a number of other issues, and create a lot of problems for care of those patients. Other forms of neuromuscular scoliosis are arthrogryposis, multiplex congenita, right? This is about 5% of these patients have 2.5 to 69% of these patients present with scoliosis. Many of them present at birth. The progression is variable. And again, it's associated with pelvic obliquity. And as many of you may already know, patients with arthrogryposis, those curves can be quite rigid, quite difficult to treat, quite bloody. We try, again, to do conservative measures, bracing, casting as well. In terms of these patients, when using them in the early age group, utilizing things like growing rods, vectors, magic rods, they're not quite as successful, and oftentimes the curve rigidity prevents the optimal correction of the curve. Here's a patient who presented at the age of 2 with a 38-degree curve. And as you know, over time, the curve got progressively more larger, but it also got progressively more rigid. And after 5 years, again, this patient was treated with a growing rod construct. As you notice that there's still, we went to, in this particular case, it was taken down to L5. There is some residual pelvic obliquity. Overall, doing well, and will be converted over to a definitive fusion to the pelvis at one point. Another form of neuromuscular scoliosis that we commonly see is Rett syndrome. Rett syndrome, in these patients, they develop a neuromuscular scoliosis often. It usually, remember, the way Rett's is it mimics cerebral palsy in a number of ways, but as the child ages, they become more and more symptomatic. So early on at birth, they may not seem relatively normal, but as they age on is when they start to show the signs of progressive neurological decline, increases in spasticity, cognitive function changes. And a lot of times these patients will present at the age of 3. The vast majority of them by the age of 15. The curve continues to increase around, it starts to become more rigid around puberty. Oftentimes, ambulation is protective in developing scoliosis, but not always. This is where it becomes a much more complicated issue of how we're going, or why we're going to treat these patients, because I have a number of the patients with Rett syndrome similar to CP that are ambulatory. And because of the progressive nature of the Rett syndrome, it's important to kind of make appropriate decisions on their fusion levels. Oftentimes, I will fuse these patients to the pelvis. I have a pretty extensive conversation with the family about what that may mean in terms of their ambulation as they go on. However, what I find is even if you do fuse them to the pelvis and you do a good reconstruction of their sagittal profile, oftentimes they're able to maintain their gait pattern pretty well. That data has been kind of also borne out through some patients fused to the pelvis at DuPont. And so personally, I find that they oftentimes are able to ambulate well post-surgery, but at the same time, it's one of those things where I think it's important to take these patients down further, because as they progress, they start to develop a fractional curve if you fuse them to, say, L4 or L5 at the lumbosacral junction. Here's a patient that initially presented at the age of 3 with a 30-degree curve, managed for 6.5 years with bracing and wheelchair modification. Curve began to increase in size and rigidity. And again, we ultimately, our job in these situations is to buy time and avoid acting early. And once we do have to act, is to fuse the appropriate levels. In this particular case, it was important to take the patient to the pelvis. Muscular dystrophy. This is one of those things where it's evolved and changed pretty substantially since the time of with the advent of new treatment. So historically, this is a rapidly progressive scoliosis. 92% of these patients that would develop scoliosis, it would start and progress very rapidly at the onset of they moved from walking and into a wheelchair. And historically, that's what the rationale was. Here, curve progression, at least it's progresses around 40 degrees, but even in these, as historically, now my treatment algorithm has changed, but historically, I would, as soon as they were wheelchair bound, and if they came into my office, I would start to recommend surgical, it had evidence of scoliosis, I would start to recommend surgical treatment for these patients. The big thing to know is that you want to try to do this before their pulmonary function starts to drop too quickly. And this is one of those times where preventing the progression of the loss of pulmonary function is really, really important in terms of their outcome and how they do. If you're going to brace these patients, make sure that you have a large belly hole with these patients, just because you want to try to minimize and mitigate their work of breathing. The other thing that's important to know with fusing patients with a neuromuscular scoliosis, and specifically Duchenne's muscular dystrophy, is you do not want to make them too sagittally straight. If you make them sit really pretty, really tall, oftentimes they have trouble doing simple ADL activities, which is bringing their hand to their head, bringing their hands to their mouth. So a lot of times I will purposely keep these patients in a more kyphotic posture, because functionally that actually allows them to be able to use their upper extremities better, to be able to do things more on their own. And that's an important distinction to know. That also carries with patients with spinal cord injury as well. Here's this is all kind of changed pretty dramatically with the advent of medical treatment for this. So deflazacort, which is a treatment option for muscular dystrophy, has dramatically changed the way we see the outcomes. I see a lot fewer patients with muscular dystrophy and scoliosis. The 20% of these develop scoliosis, and 1/3 of these patients, the ones who had developed scoliosis, they usually had to come off of the medication for one reason or the other, and that's what usually drives the progression of the scoliosis. So here's an example of somebody on the treatment path for muscular dystrophy. Stopped taking their scoliosis or deflazacort at late 2018 at the age of 19, and the curve had started to progress again, and it's progressed to 57 degrees. So when is a child not a candidate for surgery? If you have a stable curve that's not progressing, flexible deformities, if their BMI is really, really, really low, then you have to be really cognizant of their issues around wound healing. Repetitive and frequent pulmonary hospital admissions, which is kind of a proxy for medical fragility. The combination of those two things create issues around surgery. You really want to have these patients optimized nutritionally. You want to have a good resource center to be able to kind of follow these patients and prevent any issues for them. Have a good team around you to be able to do these things safely. The other part of it is when the family and the caregivers elect not to have it. Remember, surgery in these patients is an elective thing. And I have patients, total care patients with curves measuring 140, 150 degrees. They're stable, they're comfortable, not in pain. The family is comfortable, they don't want to take the risk of surgery. It's perfectly appropriate in those instances to watch the scoliosis. It is, however, important to also be very clear with the patients of the caregivers what that means. Also, when is a child not candidate for surgery? It's if there is a medical comorbidity, such as like a cardiac one, active infections, and again, the social situation we talked about. Decubiti are a big problem in patients that are total care. Where they are, if they're in a home, if they're at home, usually they have solid caregivers. Oftentimes they'll be able to protect them from this. But like if they're in a facility, their risk of having these complications actually go up with the decubiti, and that's where I get less aggressive about wanting to treat them surgically. The treatment algorithm for these is when to go to a growing rod and when to go to a definitive fusion. I'm a little bit different with this. For me, it's kind of a size growth-based phenomenon. So if they're under the age of 9 or under the age of 8, I tend to go growing rod. After that, I tend to lean towards a fusion. I want to try to get their T1 to T12 height maximized, but at the same time, especially in total care patients, repeat surgery can be dangerous and a problem. And so I may lean on those patients to go more to a definitive fusion. And I've done kids that are 8 years old that have in total care with patients that are 8 years old and have done quite well. So I probably lean on the definitive fusion side at an earlier age than the growing rod or minimally invasive growing construct side. But that's kind of the way it breaks down. So after the age of 9, you can kind of go into definitive fusion. Under the age of 8 to 11 is where you could still consider a growing rod. So what are the big risks anytime we treat somebody with scoliosis and cerebral palsy? It's a wound infection, wound dehiscence, the bone not healing, implant failure or pullout, PJK, proximal junctional kyphosis. In the medical side, you have the pulmonary risks, you have decubiti, and other worsening medical comorbidities. So the value of preoperative labs in at-risk patients is quite high. These factors really in patients who have a history of gastrostomy tube, right? They had a higher relative risk of complication. The value of same for tracheostomy, same for transferrin levels. So low transferrin levels and high transferrin levels were pretty indicative of increased risk for complications. So as we all know, preoperative optimization is critical. So kind of going back to the idea of a gastrostomy tube doesn't increase their risk of surgery, probably. It's probably a marker for other factors that are going on that is causing their risk. So nutritional, probably ideally. So preoperative optimization is very, very important. So I'm willing to take on a larger curve if I can optimize them ahead of time. So being patient, none of this is an emergency. None of it needs to be done urgently. So it is okay to be patient. If a curve progresses 10 degrees, but nutritionally they're doing better, and they're optimized medically, they're going to the surgery is going to go much smoother for you and for them. So, spending time to optimize their nutrition, optimize their pulmonary situation, their anesthesia, really get all of the caregivers and the physicians on the same page prior to surgery, because this is a complex surgery. There are risks associated with it, is really, really important. Make sure you have a complete lab panel. UA is critical. I'm not a big fan of the MRSA nasal swab, but the other things I would be on board with. What are your goals to the fusion? It is not to make the spine straight. It is to prevent curve progression. It is to level their shoulders and then to level their pelvis. And if you can maximize their T1 to T12 height, that's great. But sometimes that may not be what you need. So what I would say is single stage operation. I tend to be an all posterior person, and I firmly believe in that, especially in the total care population, and to try to do it really kind of safely. I'm a big fan of intraoperative halo or Gardner-Wells tongs, as well as femoral traction. Usually this is done to maybe like 10 to 15 pounds on the head and another 10 pounds on the pelvis. And as you're, or the femoral pin, and as you expose and as the muscles relax, you'll often find time that the spine tends to straighten over and the pelvis tends to level a little bit better. Okay, so this is a patient a paper out of WashU, where they had done it with posteriorly and anterior posteriorly. The posteriorly construct had a lower blood loss. Overall pulmonary complications were lower, and outcomes were quite similar. Radiographic outcomes were quite similar. It's always good to have backups. The bone quality here is relatively poor, and so fixation is important for me. I like pedicle screw fixation, but at the same time, with the advent and the use of sublaminar bands and hooks, or the advances of sublaminar bands, that's another option that we have that really does a great job of holding the spine. And then just be careful in patients that are very osteoporotic, especially in patients who have seizure meds on board. That can really cause issues with their bone quality. Here's another patient sitting in tolerance, no G-tube or trach. And this patient is a wheelchair ambulator. You notice that there isn't much in the way of pelvic obliquity. in these patients, I work hard to stay out of the pelvis. This is a little bit different than my Rett syndrome, where I tend to lean down to the pelvis in most instances because of the progressive nature of it. In cerebral palsy, it's relatively static, and if the pelvis is level, you just fuse I would fuse fairly far distally to the most stable vertebrae, but at the same time, I would try to stay out of the pelvis as best I can to improve their walking. This is a left-sided hemiplegic patient who's had progressive deformity. In these situations, I tend to treat them more like AIS, and I think they tend to do relatively well with that component. And so here we were able to go to L4. So there's surgical indications for patients with a hemiplegic or diplegic CP tend to be more analogous to idiopathic. You can go a little shorter on the fusion, but not much, so you don't have to necessarily go to the pelvis. And the patients don't really rebalance well, kind of thing. So like a selective thoracic fusion in a patient with cerebral palsy, probably not the best idea. So you probably include that component, but at the same time, you can go safely to L4 of those areas. So for me, the biggest thing is to do for neuromuscular is pontiosteotomy, posterior releases, halogravity, halopelvic tract or halofemoral traction works quite well. The important thing is to focus on the coronal plane deformity. You don't need to derotate these patients, so you don't need uniplanar screws. You don't need some of these other screws. At the same time, you want to put the head right over their pelvis. You want to be fast and efficient, so the quicker you do this, the better they'll do. Nutritional wise, you want to optimize them as quickly as you can. Our plastic surgeon at my old institution recommended we start drip feeds or TPN immediately, and that's been kind of my practice with this, and they tend to do really well. Getting them out of bed really quickly, a really aggressive chest PT, respiratory PT is quite important, and of course prophylactic antibiotic and close wound follow-up. Meticulous closure is really important on these patients, and we often do a special dressing in the lumbar spine to try to prevent soiling of the bandages through, especially if they're urinary or bowel incontinent. The highest risk of problems, the highest risk of complications is superficial wound infections. So make sure you have a midline incision, thick flaps, layered closure, a drain. If you need to, you can have plastic surgeries, specifically in cases where the revisions or redos or growing rod. Sometimes that's what I'll do. The occlusive post-op dressing is really, really important. And I'll be very liberal with using it in an incisional wound vac for these patients really quickly. So in conclusion, medically, orthopedically challenged patients, it's really important to optimize these patients. The techniques really need to follow around balancing the spine and getting as much length and keeping the head and the pelvis level. I tend to advocate an all posterior approach with multiple posterior column osteotomies. And again, in my practice, I think oftentimes these patients are nutritionally compromised, poor bone quality. I like multiple fixation points. My practice tends to be screws, but some laminar bands are fine, whatever that works in your practice. I think traditional Galveston technique is phenomenal as well for the patients that are from overseas. But I think in my practice, it tends to be iliac bolts or S2AI screws and an all pedicle screw construct. I think that's it. Any questions or concerns for me?
Thank you, Dr. Asghar, for that excellent presentation. There are a couple of questions that have come up. One is, do you think that magnetic controlled growth rods have revolutionized the treatment of scoliosis per se and also neuromuscular scoliosis?
I think they've impacted it positively in a number of ways. I mean, there's still, so what I would say to you is, to be clear and honest, they still have a lot of issues, right? And what they have done is sometimes they don't. There's in the U.S. there's been recalls around the cam and the mechanism failing, so they're not perfect. But in the idea in terms of young patients with neuromuscular scoliosis, keeping them out of the operating room, yes, that's a huge win. And the less we put those patients in the operating room, the better they do, and the trauma to the family and things like that, and the cost to the healthcare system. So I do believe in its potential. I do think that there are some things that we have to work around in terms of their development to continue to improve the technology.
Do you think that can be extended to other forms of scoliosis as well?
So for neuromuscular scoliosis and early onset scoliosis, I think they work quite well. My concern with some of the posterior-based distraction techniques and other forms of scoliosis is that they are kyphogenic, and they can alter your sagittal balance, so they can drive patients forward. So you kind of run into the old Harrington rod issues of having patients that are imbalanced. So one of the things is like I know we don't have it as prominent in the U.S., but there's been a lot of advocating of the Melati minimally invasive technique, and I didn't speak to it for neuromuscular scoliosis, and I've seen people advocate it for other conditions as well. I think it's a little problematic to utilize in patients that are ambulatory. And what I can show you is historically patients who have like vectors, T2 to the pelvis vectors, how that's it even in very young kids who theoretically have the ability to compensate for it, it'll throw their sagittal balance off quite a bit, and it'll draw them very far forward. So I think with posterior distraction techniques and limited fixation points, you can do things to draw people forward. And so I would be careful in applying that technology to a broader spectrum just yet. If there's a better way to control everything in a 3D way throughout the curve, I think then you have something that you can utilize. But right now, when you only have fixations at the top and the bottom of a curve and you draw them forward, that creates issues.
And how are your incisions like for these magnetic control rods? How many incisions, how extensile is the procedure?
So I do usually, so I'm a 6 points of fixation person up top. So I do a small incision up top. I usually plan it with fluoroscopy. And then I usually in the lumbar spine, unless there's some other reason for it, I'll do a small incision at the lumbar spine. One of the things I've been playing with, and I have 2 cases of them, is I'll do a small opening in the mid-thoracic spine, where I'll do a sublaminar band and tie it around the rod to try to get some apical control of the curve. I don't have enough to be able to tell you how that'll go yet, but but usually there are small incisions, and it's a tunneling technique. My partner does one long incision and still passes everything submuscularly. He feels just doing it in one long incision and doing it that way aesthetically looks better, and it makes it easier for him to reduce the rod. So there's a multiple ways to do it, but I do a multi-incision technique.
So in that case, the advantage I think is when you have a medically unfit patient, and you can really go in and finish the procedure in a shorter period.
Yes. So your blood loss is less. The speed at which you can do it is less. The physiologic load on the patient is less. So there's a number of reasons why there's a benefit to it. The issue around it is it ideally works for patients that are still growing. Can you do it something like that in patients that are not growing? The problem with that becomes is you have an area that's not fused, and you know, motion beats metal every time, and so eventually, it'll probably fail in that sense.
And what are the complications do you expect when you use a magnetic control rod?
So the same actually, so what I would say to you is they're the exact same complications with a traditional growing rod, except that you can have one of them, the bigger ones is the cam or the mechanism doesn't lengthen. You can get you still can get infections. You can still get PJK. You can still get rod breakage. The rate at which all of that happens is lower. So your rate of so the kind of the analogy I always give is like anytime with a growing rod, every 5 interventions, expect one major complication. If you look at statistically, the benefit of the growing rod is that, or the magnetic growing rod is that it's not the time to the number of interventions is fewer, so you don't have the wound complications, things like that, but you still have the forces on the bone that cause the pullout or the kyphosis, and that's one of the issues that we have there as well.
And in the post-operative period, you apply an external magnet, is it?
Yes.
And how frequent do you place it? I mean, how do you decide on what is the timing you need to place?
8 to 12 weeks usually. I'll do it more frequently in younger, more rapidly growing patients. If as their growth slows down, I'll do it less frequently, but I think it just depends on thing. But the 8 to 12 weeks is kind of the standard of what people tend to do.
So is it one time in 8 to 12 weeks, and how frequent?
Every 8 to 12 weeks.
Every 8 to 12 weeks, and till how long? So you keep repeating the X-rays, and
no, there's different ways to do it. There's ways to do it without the X-ray, so you can utilize an ultrasound machine. So my philosophy with it is, if they're not having pain, if there's no changes in their sagittal alignment, we have an EOS imaging machine, so we have a low dose imaging machine, but just no pain, no changes in sagittal alignment, then we use alternate like the ultrasound technology to assess if the rod has grown. But I try to stay away from X-rays. I'll do them very infrequently.
Now, just the other issue is we are relying on an external technology, isn't it? So is there a hypothetical scenario that the technology does not work later?
I'm sorry, ask one more time.
We are relying on a technology of using a magnet, and
Right.
Our main principles are happening later on. So
Right.
Is there a scenario where that external technology does not work?
Yeah, the external technology tends to work. It's the internal technology that doesn't work, right? Like the cam in it breaks, or there's some issues around it. And that's where the frustration kind of comes in with it. And so, and the other thing to remember is the growing rods right now, the magnetic ones, are quite large in diameter. So in the really small patients, they end up being very proud. So I still do, and we just last week did a traditional growing rod in a patient because of the same reason. He had chest wall surgery, several ribs removed, he had a pretty large curve with a arthrogryposis scoliosis that he had developed. And then in that case, because of the soft tissue coverage issues, we ended up going with a traditional growing rod that took up less space.
Dr. John, I think that's all the questions that we have, and everyone was very, very curious to know about the magnetic control, because that is something as an upcoming technology, and as you said rightly, it is evolving, and I'm sure within a few years you're going to, in your center, you do a lot of internal distraction for limb lengthening, and I think that's one of the pioneers. You guys are from the best centers, and I'm sure as time progresses, we're going to get better and better new technology.
Yep, we're excited. I mean, I think there's a lot of development happening in that space. I think there's a lot of evolution happening in the growth modulation and the the non-fusion space. So I'm excited about where medicine or where scoliosis will be in the next 3 to 5 years.
Thank you so much, Dr. Don, for sparing your time with us. I know you're very, very busy. You have a long day to go every day. You're operating from morning to night. To get an appointment with you, it's a so difficult task. Thank you so much for joining.
No problem at all. Thank you. Thank you again. All right. Take care.
And
bye-bye.
Please convey our regards to Professor Paley.
We will. Thank you. Take care. Bye-bye.
Thank you.